So let me show you a few cases. And I want to start with where I started. The reason I got into cone beam was Jesse. I loved treating impacted canines. It was a favorite thing to do in my practice because they were hard. You had to think. You had to make sure you didn't damage other things. And Jessie came to me about 13 and a half years old. The dentist sent her over because the upper left canine hadn't exfoliated yet. And they took a panoramic image and they started doing a head scratcher saying, oh, that's why it didn't come in. So tell me what you guys think of that upper left canine. Is that mesial, is that lingual or buccal? I'll give you some PAs because the dentist took those. Is it lingual or buccal? Which way would you advise your surgeon to go in? And more importantly, which way would you pull? This is why I got into cone beam. And I think Jessie was actually just before I bought my iCat. I had her go get a new tome at a lab so that I could do this. And now I can see exactly where that tooth is and what I have to do to pull it in. But what these models do for me is not only help with my treatment, but they help me advise the surgeon what I want them to do. Because if I'm going to move the tooth in a certain way, it's not just about get a button on it and go. I have to make sure that all the bone's out of the way of that enamel. Enamel does not resorb bone. If you have cortical bone between your enamel tooth and daylight, you're going to get what many of us call ankylosis, but it's not. You're running enamel into bone. So here's how we plan. Our software allows us to put a widget on the tooth so we can place it on that canine and I can reorient it along the long axis of the tooth and I can move it to where I think the center of resistance of that tooth is. And I can angle that widget any way I want so that I can simulate my mechanics. The way I was taught to de-impact canines was strap up the case, push coil at the canine site. As soon as you've push coiled, send them to the surgeon, start pulling. Now, in Jesse's case, you can imagine if I pull in the direction of that canine site, I'm going to pull it right into the apex of the lateral. I don't want to do that. This tooth needs to move completely buccally. It can't go occlusal. That's going to get me into really big trouble. And all that bone that's on the buccal of that tooth has to go. Here's what it looks like on the axial slice. This is where I want to go with that tooth. So anything that's gray in there, notice the eruption follicle, all that radiolucent area, all the gray around it has to go. All the cortical bone on the outside has to go. So what we do in treatment planning is we design the plan, which you're going to see on this movie, and I send this plan to the surgeon digitally, right? So now I'm communicating through wires all the time. I don't need to take the models and show them all these things. I send the plan over and tell them, here's how I'm moving the tooth. This is my simulated mechanics. Anything that's in the way of that crown, bone-wise, get it out of the way. So anything above the CEJ that's bone, get it out of the way. Because this is how I'm moving it, because I don't want to touch the lateral incisor or anything else. And the surgeons now know they've got the instructions. They can look at it and say, I know just what to dig. Most surgeons are quite conservative. I only use 2 oral surgeons. And both of them are mandated that they use 3D technology. I won't send to a surgeon that wants a pan because they can't see this. They can't see this bone, and I need it. Here's the mechanics for Jesse, super simple, because all I need to do is get traction on the canine, upper lingual arch, and a cantilever from the upper left first molar to the impacted canine, and that cantilever sticks straight out into the vestibule when it's unactivated. This is what it looks like at tie-in. And because of my prediction model, you can actually tell, I know where that tooth is going to come through. And lo and behold, that tooth comes through just where I want it. And I don't care if it comes through unattached tissue. I care more that I have the roots on all the other teeth when I get it down. So once it's through, it's a much easier orthodontic problem. It's leveling and aligning. And we finished Jessie in 21 months, 8 of which were no braces, just the cantilever to get that canine into the right position. Then we strapped her up. So she only had about 13 months of braces. I like when things hold up. The only counter I have to John's lecture yesterday is the thing I get out of retention, and I'm already changing my protocol. John, where are you? I'm not gonna see him as much as I am. But what I love about retention is I can see what fails. That makes me a better orthodontist. So here's what Jessie looks like almost 2.5 years after ortho. Here's her end of treatment. This is a couple of days after a connective tissue graft on that canine. Here's what she looks like 2 years follow-up. Nighttime Hollies only, that's it. So when cases hold up, I think I want to repeat that. I want to do that again and again. And when they fail, I want to get in and study and figure out, well, what did I do? What did I miss? What's that little thing that I'm not getting? And I think that's how we learn. Now, my impactions became more complex. And again, initially I thought this is all I got into cone beam for. So meet Annabelle. Here's her malocclusion. I want you to look at the occlusals. She lost her lower right primary first molar, and that's not the bicuspid coming through. That is her lateral incisor. So without this model, I mean, all of us can see that the tooth is off and there's a potential transposition happening here. But for me, without this model, it's really hard for me to determine what my mechanics need to be to get that lateral incisor where it's supposed to be. A lot of us think, just put something on it and just tip it. What I want you to notice from this rehearsal on Annabelle is notice how much apex movement has to happen, how much mesial movement of the apex has to happen. This is bodily movement of the lateral. A lot of us think that these teeth just upright with controlled tipping right around the apex. They don't. There's a center of resistance with impacted teeth, just like with teeth that we move into extraction spaces. So to get bodily movement on a tooth like that, I want to know how heavy I have to lift. And so to see where the root needs to move and how much moment or counter moment I have to put on that tooth allows me to design better mechanics. So if I just want to push coil that lateral incisor back into its happy spot, I know I need to create a counter moment that sweeps that root forward to get it out of the transposition. So if I think I'm going to go put my bracket on in the normal spot and just push coil that, I'm going to get in trouble because the tail of that root is not going to move. I need to create a bracket position that gives me the proper counter moment to get that root to sweep underneath where it needs to be. And this is how I design all the mechanics, including just regular orthodontic alignment. Because there's some things where you see the roots under there and they're not in the spot that you would expect them relative to the crowns. And I want to know that before I put my appliances on. So Annabelle had 9 months of early phase 1 orthodontics. I'm going to share with you a little bit more about what we do for phase 1. But here's where we got her to in 9 months. All I wanted to do is get her expanded because she was narrow in the maxilla. And I wanted to resolve this transposition of the canine and the lateral. Here's what she looks like on the occlusal. Now, I'm not focused on the crown. You might look at that crown and say, whoa, why didn't you derotate it and slam it right up against the central? There's a canine under there, and I want to just make sure that I get the roots out of the way of that erupting canine. So I knew from progress images that that root was out of the way, so I basically just held it there until things erupted. And that's it. And I let Mother Nature have it back, and she did a really nice job making my phase 2 ortho really simple. 15 months of cleanup, and we're able to take her from a pretty crazy transposition, a little bit of nudging of Mother Nature, and getting her to a place where now we have really nice root alignment. And if someone just showed me the picture on your right and told me that lower right lateral and canine were almost transposed, I would say, no, I don't believe it, because I'd like to see more of a trace of the crime, or you normally would. The earlier you catch these things, the better they resolve. I'm a big fan of early treatment. Our practice is primarily 7, 8, and 9-year-olds. 85% of our exams are 7, 8, and 9-year-olds. I have 5 active adults. My job, for those of you who see adults, is to put you out of business. I know that sounds funny, but I would love all the kids to come through and get really great bites and alignment and faces where they never have relapse, so they never have adult problems. That's my dream. I know it's not going to happen, but we focus most of our energy on kids like Annabelle. But then there's kids like Angie. Now this is recent, and it came to me super head scratcher, because I'm not the first orthodontist. I'm a second opinion, mid-treatment, because things aren't quite working out how we thought. You can't really see the pano on this, but obviously, as many of us do, we work in the world of two-dimensional panoramic x-rays, and even if that pano was super clear, you'd be able to see the canines are off course, and you'd be able to appreciate from the clinical photos that Angie is narrow and needs some phase 1 orthodontics. So the orthodontist did that, and Angie couldn't tolerate an RPE, so they went with the Schwartz and kept turning. She would take it out a lot, and you'll notice in the transfer notes that the very bottom switched to an upper Schwartz because the patient was having difficulty eating. So Angie took the Schwartz out a lot to eat, which means we got a lot of expansion dentally of the permanent first molars. Notice how they're kind of leaning out on the maxilla. But look at her maxilla and notice the V shape now, and the place where we need the width is around those impacted canines. So she has really wide molars now. She's almost into transitional dentition, which there's very little roots on the deciduous. So I ask you, what's the solution? How do we expand her to get these canines in place without making the dental problem worse? Here's what Angie looks like. I want you to go through your diagnostic list and figure out what you do in your practice with her. If you're going to expand, is it going to be dental borne? If so, which teeth are you going to grab? If you look at the decompensation of the maxillary molars, if I put them back into their normal curve of Wilson, normal axial inclination, notice how big her transverse discrepancy is. This is my rehearsal. This is what I want to do. And now I have to scratch my head and say, how can I do that? What do we have in our toolbox as orthodontists to do that? And as many of you have probably tried, Marpies are here. And I don't do Marpies on kids. They're usually reserved for older kids or adults. But Angie was one that I said, there's nothing to grab onto. I need a lot of skeletal anchorage because those canines are in big trouble. So, knowing that we were going to have to put a Marpie in a child that already had tolerance issues, I said, we're going to go in once and we're going to do everything. So we put the Marpie in surgically. She was under when we put the Marpie in. And I did bilateral exposure of the canines at the same time. Notice how aggressive that exposure is. I know a lot of us don't like to do that, but the bone heals up. Don't worry about your surgeons being aggressive. Get the bone out of the way where that tooth needs to move. So that's her right side. Here's what the left side looks like. And then we closed her up. These are my little cantilevers, similar to what I showed you on Jessie, and started turning. What you're seeing on the left is my rehearsal, which I just showed you. On the right is what actually happened. So this is what Dr. McNamara is talking about, study. What did we do? Did it work out like the rehearsal? Or do I have to go back and start modifying my rehearsals because teeth and bodies respond differently? Here's the difference. Notice what's happening on the actual versus the rehearsal. Now this is a three-dimensional superimposition, which I'm going to show you a little bit later. And this is actual tooth movement. So what you're seeing is just a movie from T1 to T2, following expansion. Notice how the canines moved out. That was not difficult. Notice how much change happened at the skeletal level. But notice how the incisors responded. There were no appliances on the maxillary incisors at all. Look at the buccal root tip on the lateral incisors as we expand, particularly that left one. Look at how much that root flies forward. We didn't even touch that tooth. This is Mother Nature telling us, thank you, now I can be straight. Teeth really like to be straight. Our job is to figure out how do we nudge it just enough where Mother Nature can take over. And so now, in my opinion, Angie's out of the woods, because now she's got a good maxillary skeletal base and we've got the canines de-impacted.